Hello, everybody. Thank you so much for joining us this morning or afternoon. I'm Laura Doherty. I am the National Clinical Manager with Functional Formularies, and I'm super excited for our webinar titled Mix and Match, Creative Solutions for Ketogenic Conundrums. Our first speaker is going to be Lisa Vanatta. She obtained her Bachelor of Arts degree from the University of Utah, completed her internship at Brigham and Women's and Boston Children's Hospitals, and received her master's degree in human nutrition and nutritional biology from the University of Chicago. She is a registered dietitian, board certified in pediatric nutrition, and has worked at Phoenix Children's for more than 25 years in a variety of roles. In 2010, Lisa took over the Ketogenic program and currently serves as the program coordinator. Lisa co-authors the Ketogenic Therapies for Neurological Disorders Pocket Guide, as well as several other research publications. She has given numerous presentations, including most recently at the International Keto Symposium in San Diego. Her special interests include use of keto therapy in infants, the pediatric ICU, and ketogenic parenteral nutrition. She has been instrumental in the development of a ketogenic dashboard for tracking patients on the diet and home monitoring app for managing outpatients. Our second speaker this afternoon is going to be Ilisa Nussbaum. She's a registered dietitian nutritionist certified by the state of Connecticut. After earning her undergraduate degree from Boston University, Ilisa Nussbaum spent 20 years in the private sector before returning to school to pursue her passion for nutrition education. With over 15 years of experience, she now holds a master's in public health from the University of Massachusetts, Amherst, along with her RD from Yale University School of Medicine. Since earning her RD, Ilisa has worked at Yale New Haven Hospital in the neurology department, running the keto diet clinic, as well as covering pediatric GI. Ilisa plays a pivotal role in managing the Yale University Human Nutrition Research Unit and teaches nutrition at the Yale School of Medicine. The only thing she is more proud of than her numerous industry awards and published journal articles are her 3 mostly grown children and her expansive home garden. So with that being said, thank you ladies both for being here, and I'm going to pass it over to Lisa to get started.
Thank you, Laura. We're going to get started with our mix and match creative solutions for ketogenic conundrums. Here are our disclosures. Our objectives today are to obtain a comprehensive understanding of how to mix and match different forms of ketogenic diet therapy, including classic, modified Atkins, and MCT oil in a variety of clinical scenarios, explore the incorporation of blenderized tube feedings into ketogenic plans, and recognize potential microbiome benefits of incorporating whole foods, and then hopefully help you enhance your problem-solving skills through a number of case studies that both of us are going to present to you today. Before we dive headfirst into the case studies, I want to very briefly review the types of ketogenic therapies we will be talking about today. When I educate families, most have already heard about keto, whether online, from their provider, or from family and friends, but most don't realize there are a variety of ketogenic therapies, all with the same goal, to try and achieve nutritional ketosis. I like to describe it to families as an umbrella of ketogenic therapies with varying degrees of restrictiveness. I tell parents we will choose the one that is most effective for their child and may even combine different therapies depending on their child's needs. So today we're going to focus on classic, modified, and modified Atkins and how I've utilized each of these in combination and at varying ratios. MCT oil diet is not one I've readily used as a monotherapy, but rather I use MCT oil in just about all the other diet therapies to help reach whatever goal we're trying to get to improve seizure control. I also rarely use a low glycemic index therapy unless the family specifically requests it, so I don't have a specific case study where I've combined this successfully with other therapies at this point in time. So whether you're a seasoned ketogenic expert or just starting out, I'd like to start with some basics for each of the types of diets we're going to be talking about today. The classic ketogenic diet, of course, is probably the most common one, certainly in our practice that we utilize, and probably the one people are most familiar with. It uses a ketogenic ratio of 4:1 or 3:1 grams of fat to grams of net carbohydrates plus protein. About 90% of calories come from fat. All food is weighed and measured on a gram scale. Generally, it tends to be the easiest to implement for infants and children, particularly those that are formula fed, though it can be used in older children as an oral diet as well. The modified ketogenic is one that I remember talking to Beth when I was first starting out and trying to understand the different therapies, how hard it was to implement modified Atkins for some of my families. Though it sounded simple in theory, a lot of my families struggled with knowing how much fat to eat because they were allowed to eat as much protein as they wanted to eat, even if they were restricting their carbs. So Beth came up with, through the Charlie Foundation, coined the term of modified ketogenic and created a nice booklet to help dietitians like me that's calculated similarly to classic, but with lower ratios, using generally 1-to-1 to 2-to-1 ratios. And the fat content usually is between 70 to 85%, and families are often given the option on these lower ratios to continue to weigh and measure all their food, or they can use the exchange list in this booklet and use household measurements, which are given to know how much protein, fat, carbohydrate servings that they need to consume at each meal or per day using the exchange lists that are in this booklet. Because it is a lower ratio, there's less risk for nutritional deficiencies and side effects. The modified Atkins are MAD, as we know it. This is my go-to option for patients on tube feedings who are just starting to eat and are not eating enough to create meals in specific ratios. Generally, the ratio is a 2-to-1 with a limit of carbohydrates to anywhere from 10 to 20 grams per day, but allows unlimited fat and protein, with about 65% of those calories coming from fat. There's generally no weighing or measuring of food, and every time a carbohydrate is consumed, it's recommended that fat be eaten with it. This one is most commonly used with adolescents and adults due to the flexibility of it, and also because generally they have higher protein needs, which can't be achieved with the higher ratios in general. So now that we have a common understanding of what the various ketogenic therapies are, let's take a look at some case studies. My first case study is this young lady who's 5 years old. Her diagnosis is Dravet syndrome, the 2q deletion, and when she came to me, she was having 1 to 10 seizures a day, about 4 to 5 days out of the week. She was on had already been trialed, on 3 anti-epileptic drugs that didn't have any effect on her seizures, because Dravet syndrome tends to be, in our experience, very difficult to control. And the goals that mom had at the time was comfort and quality of life, and really important to at least maintain her weight, because as you'll see as we go through the case study, weight became her nutrition status became one of the biggest concerns. Of note, I had taken care of her sister several years before, who had passed away from the same diagnosis at the same age the patient was at the time mother came to me asking for help, and didn't want the same thing to happen to her other daughter. So at baseline, her formula at the time that I met her outpatient, she was on a hypoallergenic infant formula mixed at 24 calorie per ounce. She already had a GJ tube because she'd had so many issues with feeds. And she'd been fussy ever since mom had stopped breastfeeding and was never comfortable with any formula. Initially, my transition plan was to start at a 1-to-1 ratio and advance the ratio by 1 to the goal of 4-to-1 over 3 to 4 days. We typically will start 1-to-1, given 24 hours, go to 2-to-1, given 24 hours, go to 3-to-1, etc., until they're on whatever our goal is. I had planned to use a partially hydrolyzed ketogenic formula with some amino acid powder to meet her protein needs and added emulsified MCT oil to get her to the ratio, to the 4-to-1 ratio. But as you can see by the final plan, we ended up with a far different plan, which ended up including a designer elemental formula in a 3-to-1 ratio, a partially hydrolyzed peptide ketogenic formula in a 4-to-1 ratio with TPN thrown in there in a 1.6-to-1 ratio. So our final ratio is about 2.2-to-1 ratio. So let's break down how we actually got there. For this young lady, ketogenic therapy was started at the end of 2019. By February of 2020, though no real changes in relation to her seizures at that point, she did have significant improvement in cognition, activity, awareness, alertness, and she started smiling for the very first time. But along with this came what we came to describe as pain episodes with feeds since we had initiated the diet. She cried the entire time feeds were running through her GJ tube. So mom was anxious to try something different to see if it would help. We really didn't think so because we felt like it was nerve pain and it was likely related to a diagnosis. But mom was adamant that we try something. So we basically threw together some amino acids, some medium chain triglycerides, and some long chain fats, and basically dissolved it in some water. By June of 2020, so a few months later, she was experiencing weight loss. So remember, 10 kilos. You'll come to find out she was at that weight for a couple of years and we couldn't budge her at all. So mom wanted to increase the calories in her formula. She didn't tolerate any increase in rate of feed. So the only thing we could do was increase concentration. So we did that by adding an amino acid based formula, the most elemental we could find. And a month later, she got admitted for feeding intolerance and required some gut rest. So they started what we called temporary keto parenteral nutrition. And while she was hospitalized, then we tried to do a retrial of the hydrolyzed ketogenic formula, but she failed that again because of the significant GI pain. So we restarted her blend of the elemental amino acid formula with the the elemental amino acid powder, along with some MCT oil and the water. On the right is the formula. On this slide on the right is the formula that we came up with, and it was in close to a 3-to-1 ratio at this point. A month later, in August 2020, mother called me in tears. Now, think about what was happening in August 2020. This was the time of COVID was rampant. So that plays a role in all of this. You'll hear in just a few minutes. So mother called me, and during that hospitalization in July when she was on TPN, mom told me it was the happiest 3 to 4 days of her life. She was pain-free. She seemed to be happy. Whenever that tube feeding started with her formula, it was running for 24 hours. Mom reported that she was just always in pain. And mom was very aware that she had very limited time, but wanted what days that she had left with this young lady to improve her quality of life. Again, remember, her sister had died at 2 years of age at the same time with this same diagnosis in that same month. So mom just felt like she could not handle it if the same thing happened to her. So I was willing to do whatever it took, because at this point, mom had said she was now seizure free for 4 months. Mom wanted to continue ketogenic formula, and we discussed the idea of starting some home TPN. Mom felt like I basically asked mom how many hours she thought she could tolerate feeds, and mom said she thought she could do 16 hours as long as she had a break from the feeds. So we basically, I contacted GI, said, can we possibly do this? They agreed to admit her to start some TPN. To make up for whatever we couldn't in her feeds. So initial TPN was no dextrose, just a little bit of amino acids, and SMOF lipids, for those that don't know, is soybean, MCT oil, olive oil, and fish oil combined in an IV lipid formation with a goal of 2-to-1 ratio. And formula was to remain at a 4-to-1 ratio and just run over 16 hours at a volume that mom thought that she could tolerate, which was generally around 30 mLs an hour. During the course of this hospitalization, though, unfortunately, her LFT started to increase dramatically once we started the TPN. Her ALT and ASTs went up to over 700. GI then started telling mother that if these levels didn't improve, we'd have to stop the keto TPN. So we adjusted the formula. We had to do something. So we adjusted the formula to a higher amount of MCT oil, and then to give the liver a little bit of break, and we added a source of choline to her feeds in the form of sunflower lecithin, because it would also help to emulsify the blended formula that mom had been using. After a month of doing this, her liver enzymes returned to normal, and at that point, mom also wanted to be able to give her breaks off of the TPN. So lipids were changed to run over 20 hours, TPN was changed to run over 20 hours, and now her feeds were running over 16 hours. She was discharged home on TPN in a 1.9-to-1 ratio. So my goal was always to get her TPN around 2. No dextrose. The amino acids were based on how much protein she was getting in her enteral feeds. And then the SMOF lipid to provide enough calories to bring that ratio up to our goal. Enteral feeds at this time stayed at a 4-to-1 ratio over 16 hours with the sunflower lecithin and with a higher amount of MCT oil. So our final ratio was just above a 3-to-1 ratio between the formula and the TPN. Knowing that the primary goal for mother all along had been comfort and quality of life, one of the big things was mom didn't want her to lose any more weight. She was already very, very tiny as she was, and her weight had hovered around the 10 kilos for 2 years, as I mentioned earlier. We didn't think she'd ever gain any weight, but over the next several months, we made many adjustments to her TPN and feeds. And then when we saw her in March of 2021, her weight was above 10 kilos for the first time. She wasn't having any seizures, and there were bigger gaps between these GI pain episodes, and they were lasting a much shorter period of time. We thought we were on our way at this point. Oops, excuse me. We thought we were on our way at this point until, of course, as we all know, COVID made a lot of things hard to find, and that was the case for mom here, because the brand of sunflower lecithin mom had found that she could tolerate the best no longer was available, or it was very difficult to find. We thought that it would be easy enough to switch to another brand, but as we found, she didn't tolerate most of the other brands. She either developed diarrhea, then she developed some cyclical vomiting. So mom literally searched the entire state of Arizona for the brand that she needed, and she was able to secure enough for us to revert back to that brand. And by April of 2022, she was well on her way with her weight gain. Once she got back on the brand of sunflower lecithin she'd initially tolerated, she had no more GI pain, no more vomiting or emesis, and she, again, was gaining weight beautifully. And she had achieved one of the biggest milestones that we never thought we would achieve. She had turned 3 years old. She was a year older than her sister who had passed away. And this was a huge win for the family. So here's a snapshot of her designer formula and her TPN as of April 2022. Her enteral feeding ratio, again, was about 3.3 to 1. Her TPN was now about 1.5 to 1. She was seizure free, she was gaining weight well, and she wasn't having much pain at all with her feeds anymore. So we thought we were good for a while. Unfortunately, as time went on, though, that sunflower lecithin supply, even though we were now a few years out of COVID, was still getting harder and harder for mother to find. So she came up with the idea when we were in clinic one day and asked if we could try transitioning back to the hydrolyzed peptide formula, the same one that she had failed 3 years before, hopeful that it would work this time if we transitioned very, very slowly. So at this point, we decided not to change rate of feeds at all. She seemed to be stuck at about 34 mLs an hour by this point. So we tried multiple times to go up 1 ml at a time to try to get her off TPN, and we could never do it. So this time we decided to not change rate at all, but just change over to the new formula by 1 hour every week. So for example, if she was getting 34 mLs an hour over 16 hours, 15 of those hours would continue to be her blended formula with the sunflower lecithin, and 1 hour would be the hydrolyzed peptide formula. And each week, mom would add 1 more hour to the hydrolyzed peptide formula and decrease the blended formula. She has been transitioning. She has steadily been transitioning over to new formula, and as of January of this year, she's still not had any seizures unless she's ill. She's had no pain episodes since we started this transition, except in August 2023, which we think was related to a UTI, urinary tract infection, and tolerating formula without any issues, no vomiting, no anything. And at her most recent visit earlier this month, she's almost completely transitioned over. We are now at 34 mLs an hour over 2.5 hours of her blended formula and 13.5 hours of her peptide formula. She's thriving. The last visit, she was even trying to push herself up to a sitting position. She's very alert. She's very interactive. And here's her current formulas, plural note, because she is still on this designer funky blended formula with the sunflower lecithin in a 3-to-1 ratio. She's on the hydrolyzed peptide formula, which is basically just mixed with water to make a 4-to-1 ratio. And then we've adjusted her TPN for calories, for her weight gain, etc., and it's come out to about a 1.5-to-1 ratio. So when all combined, that's what made the 2.2-to-1 ratio as her final ratio. And she seems to have good seizure control as long as her ratio is just above that 2-to-1 ratio. So what are some key points we can take home from this case study? We need to think outside the box when we're creating designer or blended formulas. If we hadn't thought to add some choline, which is important to package up the fat in the liver and get rid of it, decreasing the stress on the liver by adding more MCT oil, or not being willing to try some parenteral nutrition, she may not have been able to continue on ketogenic therapy, may have had increased seizures, and may not have lived at that point. MCT oil was a major component of her blended formula for a long time, and because it's so easily incorporated in its emulsified form, we didn't have to use as higher ratios, yet we're still able to maintain seizure freedom, especially with the TPN being at a lower ratio. And SMOF lipid turned out to be one of the most essential parts of her nutrition prescription. We didn't have to use super high amounts for the SMOF lipid. However, because it contains fish oils in it, the amount that we had to use did increase her vitamin E levels. So it is something that we had to pay attention to, because high vitamin E levels can lead to hemolysis of your red blood cells. So what we ended up doing was cutting her vitamin E dose in half in her TPN. But when we did that, we also noted that cut back some of her other water-soluble vitamins, and particularly her vitamin C level then started to drop, and she developed some vitamin C deficiency. So we have had to add some vitamin C and cut her vitamin E multivitamin in half, and now she's maintaining beautifully. And we haven't had to make any adjustments to her TPN in a very long time with respect to those supplements. My next case study I'm going to share is how to navigate a patient that has G-tube feeds, but also likes to eat by mouth. This patient is an now 8-year-old, who came to me with Snyder-Robinson syndrome, a rare genetic syndrome. He was having 1 seizure a day, had already trialed a couple of medications, and neither one seemed to be helping. A G-tube had recently been placed only a couple weeks before my initial appointment with him for diet initiation. So on my initial assessment, you can see I diagnosed him with some pretty significant moderate malnutrition, and it was getting worse, which was obviously why the G-tube was placed. But unfortunately, no one had really explained to mom how to use the G-tube and really helped her much with that. So at baseline, when I met her, he was not eating breakfast or lunch anymore, because she was giving some night feeds of a standard pediatric formula. During the daytime, he was eating about 1 cup of purees that mom pureed together. The variety varied, and you'd spread the purees on a couple of crackers, like a Ritz cracker, to make little sandwiches for him, because he liked crunchy things. And this was mostly offered at school or at dinner time. And then also at school, he had been getting a oral nutrition supplement, chocolate flavored, to try to get him to get more calories in. He was not being G-tube fed at school at that time either. G-tube was only being used at nighttime. And I think initially he had been prescribed 3 cans at night when he was discharged home with his G-tube. So when I met him, my transition plan initially was to correct the malnutrition first, transition to a 4-to-1 formula over 3 to 4 days. And we started with chocolate because I wanted to continue to encourage as much oral intake as I possibly could. And then I wasn't even going to touch the oral intake he was taking, because if we didn't get seizure control with a change in the formulas, then we could discuss about changing up the oral intake. So what did we finally end up with? We ended up with a standard ketogenic formula in a 4-to-1 ratio, with bolus feeds during the daytime, plus some as a night drip, as well as fluids in a night drip, and then worked with mom on more keto-friendly foods, but didn't prescribe any particular ratio for those PO foods. So how do we get to this plan? As I mentioned, he recently had that G-tube placed 2 weeks prior, and it was clear on my first meeting with mother, she was not given much education on the G-tube, or at least didn't seem to remember how much formula or fluids or anything she was supposed to give with the G-tube. And he also consumed some food and supplements orally. So everyone had told me too, when I looked at the inpatient information, that he was super thin because of his syndrome, which turned out not to really be the case. In his initial diet evaluation in late December of 2021, his weight, he had slightly improved, but he'd lost weight since the G-tube had been fed, which was what I was most concerned about. And when he came back for education, which we usually do a couple of weeks after we do our initial assessment, Mom reported he was having distension and gas with the standard pediatric formula she'd been using for his nighttime drips, and she had cut it back to only 2 cans a day, but had never told anybody. So he'd lost even more weight by this point. So my first priority was, let's get him nourished again. So I changed him at that visit to a standard pediatric formula that was higher calorie, the 1.5 calories per ml, and I increased the amount that he needed to get to 4 cans a day. And then I also provided her with some guidelines of how to give that. And 2 weeks later, he had improved his weight significantly and increased by a couple of kilos because he was so malnourished. And by now, he was ready to start transitioning to ketogenic formula. So here's just a snapshot of what his transition looked like. Since Mother seemed to have, it wasn't an education problem. Mother was well educated. It was just, it was so new to her that I think no one had really taught her much before she got discharged from the hospital. So she had a lot of difficulty understanding how the tube feedings worked, how much she was supposed to give of everything. So my plan was keep it as simple as possible and replace 1 can of the standard pediatric formula with 1 carton of ketogenic formula over a period of 3 days until we got to the all just ketogenic formula. And this seemed to work quite well. And we continued to use chocolate so that he could have some for his lunch at school. At his 1-month follow-up now, we had some great weight gain. He had not had any seizures, so he's doing better, but we were still inconsistent with what we were giving him. I found out at this visit that Mom was still offering him the standard pediatric chocolate formula, or that's what she was giving to the school to give to him, because apparently he had refused to drink the ketogenic formula, which I'd gotten in the chocolate flavor for him. So, and at this point, he was not getting the G-tube feeding at school. Mom didn't even know that was an option at the time. So, and the school was still giving him purees such as applesauce, and they were giving him the crackers, so all the things that I wouldn't have recommended. And it was hard to determine how much formula foods or fluids he was actually eating. So at this point, because we were supposed to have been fully transitioned, I just created a whole new regimen and did it based on what Mom told me. He didn't like to eat breakfast, and school was so early in the morning, Mom wasn't able to get a feeding in. So his first feeding was at school with water. Then his next feeding was when he got home from school with water. And then Mom liked to just feed him whatever he wanted to take orally for dinner time. And then we would just start his tube feeding. So all of this was based around their schedule and allowed him to eat whatever foods he wanted as he could tolerate. Weight continued to improve. He tolerated this new formula regimen at a 2-month follow-up. He was now seizure-free, and Mom had made some small changes in keto-friendly foods, offering him more avocado. He apparently loved cashews because they were crunchy. She had switched to like a low-carb yogurt because that was something he really enjoyed. So we just worked on giving her some different options of things that she could try with him. So now fast forward to 2023, he'd done great, but now he had to have hip surgery at the beginning of January 2023 at an outside hospital. And Mother worried the formula would soak through all of his bandages and diaper changes were painful. And so she didn't want to give him his normal feedings, both right after the surgery and during the time he was hospitalized, and then even when they discharged him home for the surgery. So when I saw him in February, so this is a month after, he had drastically dropped weight. Again, he dropped 2.2 kilos. Mom then reported to me she'd been overwhelmed by all of his multiple therapy appointments. So not only had she decreased his volume that she was giving by the G-tube, but she hadn't been offering him any food by mouth. Even though that may not have been a significant source, she had stopped doing that as well. So the weight loss was pretty drastic. So at this visit, I increased him to 5 cartons of his ketogenic formula, just replacing some of the water. So we didn't change the volume at all, just replaced some of the water and gave more formula, and continued to allow him to take food by mouth without weighing and measuring anything, whatever she could get in him when she had the time to. So he gained back his lost weight by April. He's beginning to eat by mouth at home, and school was doing a G-tube feeding after I had created the regimen a few months back. And after not having seizures for almost 2 years at the beginning of this year, it turned out he was now back up to eating double the amount of his PO from a year ago, and he started to have a couple of seizures. So at this point, I discussed with Mom doing a modified Atkins diet and even helped her understand how to use an app to track his carbohydrate intake. She'd already been doing a lot of good keto friendly foods and using keto crackers, etc. But by the time I saw him in February, it sounded like one, we cut back his calories because now he was gaining weight too much, too quickly, not taking as much by mouth. So we ended up leaving his oral intake as ad lib. So his current plan now is 4-to-1 ratio of formula. His food that he eats by mouth, we've left it as no ratio. So final ratio, I couldn't tell you, but I just know that his seizures are now back in better control. So we may have to make some modifications. So what are the key takeaways at this point? If the seizures persist, rather than changing his food intake, I had planned my next step would be to add some MCT oil. And I will often start with as little as 5 mLs mixed in purees and increase every week as tolerated to a goal of anywhere. Most kids I've found can tolerate 30 to 40% of their total calories pretty easily. So that would be my next step. And I've already had the initial conversations with mom about that. For any oral eater who has a G-tube, we've also discussed that they can use the G-tube to give any additional fat that we would need to keep that ratio consistent, whether he's eating orally or whether he's just getting a tube feeding. So I suggest they give some of the fat prescribed for that meal at the beginning and then some partway through and then at the end. And this allows them to still eat and enjoy the foods without seeing them swimming in all the extra fat. And I use this quite frequently with any patient who has a G-tube. And it helps tremendously with the families adjusting to it as well. And then I also review with family what foods are keto friendly, how to figure it out. And I created this graphic because I think it really simplifies it for families when they're looking at labels and trying to decide if they can use a keto cookie or a keto cracker. They'll tell me, well, speech therapy wants me to bring something crunchy or, and they don't want to bake something. They don't want to make something. So what can I give them to help them? And so I go over this, that if the grams of protein plus the grams of net carbohydrate are greater than your gram fats, then it's probably not a keto friendly food unless they can add a little bit of fat to it. So I have them look at that and try to get the foods to be at least a 1-to-1 ratio that they'll offer at that point. So my third case study is a patient who requested transfer to me after he was hospitalized while I was covering inpatient. The patient had been lost to follow-up for almost a year when they showed up at the hospital. He's a KCNB1 mutation. He'd been tried on 3 medications. He wasn't having super frequent seizures at the time, and we were most concerned about him having refeeding syndrome. So this was our biggest concern. And the plan was to transition him by just using oral supplements from my colleague and even just getting a food log because it sounded like he was eating everything orally. But family never completed the food log. He got lost to follow up and he got admitted. And apparently never tried the oral supplements from what we can tell. So when he got admitted, not much had changed from his initial. He was breastfeeding 4 to 6 times a day he was probably at that time 3 or 4 years old. Not much had changed with the breastfeeding, still doing it for 30 to 45 minutes, taste of keto-friendly foods for the family, and then they were mixing 1 bottle of heavy cream, or about 50 grams, plus 135 mLs of alkaline water. That was his bottle that he got if he wasn't breastfeeding. This the parents had made up completely on their own. He'd had a 9-pound weight loss since January of 2022, most of it happening since July, and we were seeing him in September. His EGD and MBS were both considered normal. He was eating bites of keto-friendly food, but had developed significant feeding aversion because the way parents had been continuing to try to get food into him, or this bottle of heavy cream, was using a syringe, forcing him to eat. In the hospital, of course, we wanted a tube feed placed. The family was not ready for it. We placed an NG tube, and it was placed 11 times before the family finally agreed, because he pulled it out all 11 times before they finally agreed to a G-tube placement. So as we suspected, a feeding evaluation was completed, which showed some significant discoordination for a lot of things. And because of his significant delays to take oral intake, a G-tube ultimately, like I said, was placed. And again, I decided let mom breastfeed. It was really for comfort, both for her and for the child at this point. So it wasn't worth arguing about that. So we had no ratio for the breastfeeding. That was ad lib. We didn't even try to have her do formula before or after or anything like that. He was on a 4-to-1 ketogenic formula is what we did for his continuous feeds, which is what we started him on, and no ratio for the food at this point, because really all he was doing was what mom termed a keto cracker, which was some brand of a keto-friendly food. After 1 month after he was discharged home, he started to eat better. We didn't ask family to weigh and measure anything because I wasn't sure how much he was actually eating. They still had never provided us any sort of food log, but he started to enjoy food again, let mom help feed him, which he hadn't done prior to the hospitalization due to all the syringe feeding she had been giving. And he was now eating keto crackers, keto cereal. Mom was using pork rinds, all things that were considered more keto friendly. And by 2023, he was much better nourished. We're able to transition him over to 13 hours of night feeds instead of a continuous drip. And then mother had figured out that he tolerated feeds best when he was asleep. And based with his current schedule, he was asleep for about 3 hours at a time during the daytime. So she gives the rest of it during his nap time during the daytime, and then still puts him in a high chair to feed him some keto-friendly things. She finally stopped breastfeeding in July of 2023, and as of February of this year, his growth has really taken off to the point where we've had to cut back. So he's gone from refeeding syndrome to being a very chubby looking, darling little boy, having much less gagging and choking on foods. Parents are ready to have another MBS done to see what else, how they can help encourage and help his PO intake. So what key lessons did we learn from this one? To meet families where they're at. This mother felt extremely guilty about allowing him to get so malnourished, not bringing him in. So we chose not to place any blame, but just support mom's desire to continue to breastfeed, to allow them to trial the NG tube before they were ready for a G tube, because they never thought they were doing anything wrong. The ketogenic diet is not successful no matter what you do if you have not corrected any malnutrition. That's been our case every time, so we have to start slowly. And then the third comment I put in more about dietitians we want to calculate everything and have them do it precisely the way we think it should be done. And in reality, most parents are doing the best they can, and they're better at knowing how best can my child tolerate the feeds. So rather than telling them that they had to do, 50 mLs an hour for 10 hours at night, and then they had to do 250 mLs 3 times a day, I let the parents figure that out. And that is what led to the success finally of the tube feedings. And just because someone has a medical background doesn't mean that you can't assume they understand anything. And in this case, I think dad is an MD, dad is a hospitalist, and unfortunately he was doing keto on himself and had read that keto would help his son and had just decided to start it on their own. I'm going to skip through this last case study because I know we're short on time. I want Lisa to have all the time she needs, but this was just, you can read through the slides. This was a pretty short one because it's just a new patient, and I just wanted to illustrate for an infant, this one was on express breast milk, eating table foods because culturally, this mother is Hispanic, and culturally they don't do purees, they just feed the child whatever the family is eating. And so being sensitive to what culturally they're doing, what they're doing with breastfeeding, I always like to use breast milk if there's any way possible, and she had enough breast milk for us to transition over to a ketogenic formula, and then she had chosen not to continue to express her breast milk. He had never been breastfed because he never could latch, even from the time he was an infant. And then the other thing on this one that was unique and interesting was that he also was on medication. Valproic acid had been started, which thought controlled his infantile spasms, but unfortunately he had spasms return, which is why we started the diet, but it can change the ratio significantly enough that it actually, the liquid valproic acid lowered his ratio to 3.4 to 1. So we've continued to do that because he's in good ketones. He's got good urine ketones at this point, and we're still looking at, it's going to take a few months for us to see how effective this is. And being aware that there can be nutrient deficiencies that may not be recognizable on these kids, that he's a very chubby child because he'd had steroids prior to, and we can't just assume that just because their weight and height is good that everything else is good. He had very low vitamin D levels because of the medications he'd been on, and no one had addressed it, and his vitamin D level was only 9 at the time I first met him. So just be aware of some of those things, especially with a breastfed baby, and letting them lead is sometimes a good way to help the mom make the transition with using her breast milk. So there is an art and a balance to ketogenic therapy to improve seizure control. There's not one right way. None of these case studies, there's not one right way to do it, but many, many ways it can work. Finding what works for one patient may not work for another. That's why I like this slide, to show that it truly is a balancing act. Now I'm going to turn the time over to Ilisa to share her experiences and case studies.
Great. Thank you so much, Lisa. Ilisa, I'm going to make you the presenter now.
Fantastic. Hi, everyone. Lisa, that was really fascinating, especially the PN nutrition that you do. It's so complicated and requires such a delicate balance. I'm really impressed, especially with that one particular case study. So let's get right into it. What constitutes a blenderized tube feed? So what constitutes it is about as diverse as what can go into a BTF. We have historical accounts of physicians using, and I'm not kidding here, clay pipes and eel skin covered whale bones, attempting to feed patients who were unable to eat by mouth. And as you might expect, that turned out very, very poorly. It wasn't until the 20th century, with the development of polyurethane tubing, commercial blenders, improved surgical techniques, that enteral nutrition became really safe and effective. The blenderized tube feeds made in hospital kitchens were poured through these large bore tubes into the stomach. By the 1960s, early 1970s, these food mixtures were gradually displaced with chemically defined, sterile commercial formulas. Way back in the 1980s, that's what my kids refer to as olden times, RDs were instructed to only put water, formula, or medications through a feeding tube. So pureed feeds fell out of favor for enteral feeds. The definition on this slide is pretty straightforward. However, there are many versions of blenderized tube feeds, including full, partial, recipes made from whole foods, and those made from baby food purees. There are also commercial blended products and plant and food-based commercial products. While a homemade blenderized tube feed must be administered within 2 hours of preparation or frozen, some commercial food-based formulas can hang for hours and be delivered by pump. You really need to check with your manufacturer's standards. Some clients utilize both standard commercial formulas and blenderized tube feeds. For instance, I have some that do a standard commercial formula overnight as a continuous feed and do boluses of pureed foods during the day. And some people find that works really well. I love this slide. So I, of course, call it a blenderized diet, blenderized tube feed, but these are some of the amazing names that my patients have come up with. Obviously, my favorite is going to be poop soup, but I also enjoy Magic Mush and Poop Buster. I thought you guys would just enjoy seeing how very creative they all are. These recommendations are taken from the most recent Aspen consensus statement on blenderized tube feeds that was published in 2023. These recommendations are specifically for homemade blends, not commercial blends. My biggest concern with homemade blends is always food safety. So I really try to emphasize sanitized work surface, sanitized cooking products, sanitized devices. This is particularly important with the more fragile patients who are at risk for infection. While the Aspen recommendations call for G-tube feeds with a 14 French tube, the consensus paper does mention that nasal tubes, J-tubes, and JG tubes may be appropriate for specific patients, and smaller tubes than a 14 French can be used if care is taken. My own experience, however, is that my patients really struggle with occasional clogs, even with that 14 French tube, so it's not something that I generally recommend. If if a parent is considering a blenderized tube feed, I typically bring them into the hospital research kitchen and work with them to ensure that they understand all the proper food safety and sanitation guidelines from the beginning. I've seen a lot of scale mistakes where parents use ounces instead of grams. They're not clear on what's a volume measurement and what's a weight measurement, or they might have trouble managing the viscosity of the blenderized tube feed. Explaining this to them in person with a hands-on demonstration is crucial for success, and I'll often utilize the expertise of our diet techs that work in the kitchen to help teach these important things. While we look at these formulas through a clinical lens, it's important to recognize the social implications. Cooking alongside someone, even when what you're cooking is a blenderized tube feed, is a very personal act of connection. Spending time with families in the hospital kitchen, I found that helps bring down their walls and show them that I'm willing to work with them to create an optimal feeding regimen on their terms for what works in their life. You guys are all a bunch of dietitians, so I do not have to tell you about the benefits of whole food ingredients. You're going to see improved tolerance from that diverse gut microbiota, including all the important relief from constipation that the majority of our keto patients complain about. Parents also find a comfort and joy in feeding their loved ones whole foods and preparing these foods. The importance and significance of this cannot be overstated. We counsel our patients who eat by mouth to eat a diverse range of foods. So why wouldn't we also do that with our tube-fed patients? Here's a quick little reminder on fiber, and I'm going to zip through this because I know that as dietitians, you already know this information, but a quick reminder that fiber passes through the GI tract without breaking down. That's why we don't count it when we're calculating carb content. Most plants contain both types of fiber, but in different amounts. We need a balance of both in our gut. A couple of my absolute favorite foods to use in blenderized tube feed are green bananas, which have more fiber than a ripe banana, and also passion fruit, which you have to blend really, really well. But passion fruit has 6.5 grams of soluble fiber in a half cup. But again, these can be hard to find and expensive, so make sure your families are comfortable with this before incorporating it. Also, again, I'll mention you need a really good blender for that one. So short chain fatty acids. These are a type of fatty acid, and they are produced when the intestinal bacteria ferments fiber. It nourishes the colon's protective mucosa, it strengthens the gut barrier. These short chain fatty acids are used as energy in the gut and have been shown to reduce inflammation, help with the absorption of minerals, aid metabolism, and other health benefits. Now, insoluble fiber, you guys all know this passes straight through the GI tract intact without blending with water and can help function as a bulking agent for stool. I do want to mention on this slide that galacto-oligosaccharides are non-digestible carbohydrates that are able to resist digestive enzymes. They're a type of insoluble fiber, and they also have prebiotic capabilities because they ferment in the colon to produce those short chain fatty acids that we were talking about that regulate intestinal flora. Depending on your patient's needs, you can vary the type of fiber by changing the types of foods that you include in those tube feeds. A little word on keto and gut microbiome. Our keto patients have so many side effects that negatively impact their gut microbiome, from high levels of anti-seizure medications, frequent use of antibiotics, diets that lack variety, and of course, the incredible metabolic and psychological stress that they are under. All of these things can impact our gut microbiome. And it's not the gut microbiome and health. I want you to remember that fiber is not just about diarrhea and constipation. Intake of fiber has a reach that is far and wide for overall good health. So I want to talk just for a minute about how I decide who is going to be successful or not on a blenderized tube feed. So I consider a lot of factors. Is the patient stable? What medications might have interactions with specific foods? Are the caregivers willing and able? Do the caregivers have resources? I have a wide variety of families and a wide variety of circumstances, and it is important to be respectful of their limitations. My patients run the range. I have one patient who has a housekeeper and a personal chef preparing their child's blenderized tube feeds. And at the other end of the spectrum, I have a patient who's in and out of shelters with her 2 small children. For that patient, maintaining a medication schedule is challenging enough for her without throwing in a blenderized tube feed. And some families, they just are not interested in a blenderized tube feed, and that is okay too. We are lucky enough to live in a world with wonderful commercial formula options that are available to us. Some other things you want to consider for blenderized tube feed: you want to look at the French size. We spoke about that before. 14 or larger is preferred, however, down to 10 or even smaller has been cited in research. Commercially available blenderized tube feed formulas can be used with a smaller French size, but you really want to follow all manufacturer guidelines for administering commercially available formula. With good tube care and technique, French size is rarely an issue. If you're interested in learning more about viscosity, take a look at the International Dysphagia Diet Standardization Initiative tests. The standardized IDDSI flow test is really helpful to categorize a wide range of liquids to determine viscosity. According to the recent Aspen consensus statement on BTF, specific recommendations for homemade blenderized tube feeds for jejunal feedings are unavailable. The use of BTF in patients who are fed via jejunal pathway is limited due to the potential need for a pump and a limited 2-hour hang time. Commercial blended formula might be appropriate for a jejunal feeding in select patients, as these products have longer hang time and they might be thinner in consistency compared to a homemade blend. I want to note here too, there was a recent collection of BTF and J-tube utilization in a survey, but those results aren't published yet, so we do not have them. A few other administration considerations: cold formula is going to be a thicker formula, so it's ideal to give the feed at room temperature or slightly warm. Hang times, as we mentioned, for homemade formulas, 2 hours. Commercially available formulas are higher. You want to follow those manufacturer guidelines. Commercial formula for blenderized tube feed formulas, you want to shake or knead that package really well before administering. If you're adding water to thin your blenderized tube feed, use warm water, as cold water will thicken it. And if you're storing it in the fridge, bring it back to room temperature or slightly warmer before initiating. A few takeaways to keep in mind before I get into the case studies that we're going to zip through. Some blenderized tube feed can really be an incredible resource, but it is not for everyone. Be flexible, give families lots of options. I have families that go in and out of blenderized tube feed depending on how their child is doing, if they're traveling, if school or other caregivers are unable to reliably administer a BTF. Talk to the family in a way that withholds shame and judgment, and find out what's important to them to help them meet their goals. So let's get into a couple of case studies, and I might go a little more quickly through the first two because the third one is kind of the most interesting. So this patient, my first case study patient, has a diagnosis of epileptic encephalopathy and was having about 10 to 12 seizures every day. This is a 16-year-old man. 16-year-old teenager. We started a home keto initiation on a commercial keto formula very slowly, as it seemed like this patient had complications with every little small change. It took about 6 weeks to safely get him to a 3-to-1 ratio. And at that point, we saw a 20 to 30% improvement in seizure control. That then improved to 50% improvement in control when we hit a 4-to-1 ratio. While he had constipation, even with his non-keto formula, there was a significant increase in constipation with the keto formula. The parents were hesitant to use laxatives and stool softeners because they very strongly felt that those were increasing their son's seizures. Unfortunately, this patient also had an increase in seizures with constipation and also withholding of urine with constipation. Blenderized tube feed was really the fix with this kid. There was a fair amount of timing trial and error, but we finally hit on a schedule of blenderized tube feed every other day. When he has a blenderized tube feed, he has a large BM within 24 hours. Parents also reported improved energy, sleep, and focus. And anytime the parents deviate from the schedule, there are complications and issues. Here is a sort of typical blenderized tube feed recipe for this specific patient. We have 4 or 5 different ones, but they all follow the same pattern of dark leafy greens, high fiber fruit, various other sources of fat and fiber. This one makes 1 day's worth of feeds. And as I mentioned, parents alternate on and off with a commercial keto formula every other day. When I was working on this presentation, I called the parents who I'm using for case studies, and I asked them if they had any words of wisdom for other families considering blenderized tube feed. And this mom said it was definitely scary and overwhelming at first, but she genuinely believed it was worthwhile. She really embraced our time in the kitchen together, and I saw how much more confident she was after some hands-on experience. This next case study is a 25-year-old young woman. She's only about 40 to 45 kilograms. We continue to treat her on the pediatric service because she's so small. You can see from this slide that the ketogenic diet was wonderfully impactful for her seizures, but we really struggled with weight maintenance and constipation. She finally was able to have scoliosis surgery, and that was a game changer because it allowed her to tolerate larger feeds, and we were able to put some weight on her. But the real impact was seen with a change from a commercial keto formula to 100% blenderized tube feed formulas. That's what these parents do. We were also able to get additional free water and an additional 300 calories in her each day by doing the blenderized tube feed. This young woman has a wide variety of meals that are prepared for her. Her meals all use a commercial whole food blenderized formula as a base. And then we follow a basic pattern of 100 grams dark leafy greens, fat from coconut cream, and a variety of oils, nuts, and eggs. This mom was really big on using a variety of oils. So sometimes she would use olive oil, sometimes it would be walnut oil or coconut oil or avocado oil. She really loved to mix it up. This mom also adds a tiny cube of frozen garlic, frozen ginger, and fresh ground turmeric to every blenderized tube feed. This family has an extensive home garden. It's really impressive. And mom gets great joy and satisfaction from using greens that they grow themselves. And I also want to mention that this patient does get a daily multivitamin as well. This amazing mom wanted other families to know that the switch from commercial formula to a commercial formula plus food blend has made a massive difference. She recommends investing in a high quality blender, food scale, and silicone trays for freezing. All right, we have a little time for my last case study, and this one is so fascinating, so I hope you guys can stick around. I saw this patient at the very beginning of my career in neurology. This is a 7-year-old male. So while I look back on my notes from this patient and I totally cringe a little bit at how inexperienced I was, there were so many opportunities for learning. Because this patient went untreated in their home country for so long, the hospital course of treatment was complicated and a little bit chaotic. This family had an untreated son who, until they came to the US from China at age 6. The medical history was really spotty. It changed a little depending on which family member was contributing and unfortunately which interpreter we were using that day. Even after the patient should have been stable on the ketogenic diet, we were seeing these wild fluctuations in urine ketones and BHB levels. This was a multi-generational home, and it was clear that while mom and I had a good rapport, grandma had influence in the home, and she was clearly skeptical of the medical system here in the US. I was getting frustrated because I could see that the diet was helping, but something kept getting in the way. I suspected that additional foods were being given PO and was concerned that the family wasn't trusting me enough to fully disclose the issues that they were having following the diet. I sat down with mom, dad, and grandma and the interpreter, and the first question I asked them at this meeting was I asked them if there were any important foods they'd like me to incorporate. I learned so much from this family. They were absolutely fascinating. I was really careful to avoid judgment about what they told me, and I showed a genuine interest in learning about what was important to them. We had a great conversation about specific foods and herbs that were important, particularly to grandma, and we came to an understanding about how to safely include some of these ingredients in the tube feed. So first, let me emphasize that this list of culturally important foods to this family is not a list of foods that might be culturally important to every single Asian family. The list seems to be fairly typical of traditional Chinese medicinal foods, but I am in no way an expert. These foods were culturally important to this specific family, and that's what matters. By sitting down with them and having the discussion, I was not only able to incorporate these foods into their blenderized tube feed, but I was able to show the family that I had a deep respect for them and wanted to work with them. The kiddo was getting a commercial keto formula plus some foods PO every day at a 3-to-1 ratio. In addition to that, I came up with a simple soup recipe base that you see here that included some of their must-haves like rice and pork. I put it at a little bit of a higher ratio than the typical 3-to-1 formula that they were getting every day during the day, and I used that to balance any added herbs or other foods that the family was adding. We agreed on 1 tablespoon of any blend from the herbs listed, and every night he would only get 4 ounces of this recipe at bedtime as a nightly feed. So all in all, it was a really small amount of the added foods that were being consumed each day. This recipe had a teeny tiny impact nutritionally, keeping in mind the kid was getting regular ketogenic formula during the day. But it had a huge emotional impact on the family. Their demeanor and their approach towards me changed dramatically after we introduced this recipe. I will mention that I was so nervous about where they sourced the ingredients. We had a long chat about food safety and my concerns, and I did ask the family to only use food from reputable sources and proper packaging. These are just a couple of mom tips that some of the families said to me. So vent the G tube before the meals, really important. Adding hot water and hot bone broth to dissolve the foods, or use the soup setting on blenders, really helps dissolve the food. You can serve the food warm, not hot, warm, and it will go through the tube more easily. Vary the types of oil you use. Food safety precautions are obviously essential. A lot of parents like to prepare in batches and freeze, and daily supplementation may be necessary depending on what formula you're using and if they're getting any other formula. So I don't know if we have any questions, but I'm going to hand it back to Laura. Thank you for the opportunity, Laura.
Great. Yeah, thank you both so much. That was really fantastic. And I apologize for my mic issues at the beginning. Lisa and I have been working hard to answer some of your questions that have come in through the chat. So if you asked a question and we chatted you back, please check that. We don't really have a whole lot of time for a ton of questions. We have 2 here, though, that I will ask, and I apologize again about the time. This first question, Lisa or Lisa, either one of you can ask this. Have there been any longitudinal studies done that shows what happens with heart and blood vessels with such a high % fat diet? Lisa, do you want to maybe take that? Do you know of any?
So there are some studies done. I don't have the articles right here, but there has been, like, I think it was a 10-year study looking at the carotid intima thickness of the vessels. And there was no change in the carotid thickness. I do know that's one of them. I can pull those references, but that was not something that I have actually personally been concerned about, because the literature, the research that's coming out even more recently is that the fat isn't what's causing most of our cholesterol and clogged arteries. But Ilisa might have something more to add on that as well. I'm not sure, but I know there is a couple of studies from the past, and there's some newer literature coming out supporting that. And I think Beth recently, Beth Zupikania did a recent grand rounds for us, and I can pull that as well. But the American Cardiology Association has even come out and said it's not related. The cardiovascular disease that we're seeing is not related to the fats that we're eating as much as it is the refined carbohydrates, the processed foods, carbohydrates is the bigger issue. But I can find those references and send them to you, Laura, and you can share them with the group.
Okay, that would be great. Lisa, do you have anything you'd like to add to that?
Sure. I would just add that, yes, I have seen those studies and I agree with them and with everything that Lisa said. And I'll also add that if a parent brings up to me that they're concerned about their child's elevated lipids, cholesterol, I typically explain to them that that might be something that we would worry about in young adults, and not concerned about elevated lipids in children. And I say that
Agreed.
we'll worry about that later. We'll worry about that when they're 40.
Sounds good. And the last question is refeeding syndrome easier to manage when transitioning to a ketogenic diet than to other types of diet, both in theory and practice? Lisa, do you want to speak to that?
That's a good question, because I don't have, I mean, I've had 2 kids on keto who have had refeeding syndrome. I don't think it's any different. You treat it the same way. We had to watch for electrolyte abnormalities very carefully. And so we started with 50% of our goal calories and worked our way up about 10% a day until we were out of the woods part with the electrolytes. You just don't want to feed rapidly. So I'm not sure in transitioning to other diets it would be any different. I've used the same guidelines as I would for any other patient when I did it for keto. We just happened to be using keto formula we were transitioning to.
Got it. Well, we are 5 minutes past, so I'm going to close it there. On the screen here, you will see 2 of our upcoming webinars. These are not keto specific, but they are all about practical use of blenderized tube feedings, homemade and commercial options available. And this webinar was approved for 1 CPE, so you will get an email by the end of the day today with your certificate and the references, so please look out for that. If you don't receive that email, please just email us and I'm happy to provide it. Sometimes based off firewalls, they get spammed or whatever. And then if you'd like a copy of the slides, please let me know that as well. I'd really appreciate you also get a survey with that email. Please fill out that survey so that we can continue to improve upon these. Sometimes the tech challenges are hard to improve upon, but certainly the content and the topics, let us know what you think. Thank you, everybody, and y'all have a great rest of your day.
Thanks, Laura.